Good afternoon. Thank you, Dr. Rajiv, for giving this opportunity to speak in this instruction course of, I'll be talking about the endoscopic surgery in ocular trauma scenario. So why do we need endoscopy as an option in trauma cases? What are the advantages and disadvantages, and what are the issues of endoscopy in this situation? I'll be talking about three scenarios: open globe injury, intraocular foreign body, post-traumatic endophthalmitis, and will also be touching upon delayed cases and diagnostic role in scenarios of ocular trauma using endoscopy. Iris trauma, corneal opacification, bleeding in the anterior chamber can cause restriction or obstruction of view of the intraocular structure in ocular trauma patients. Adequate surgical view is not possible with the conventional way we are operating with an operating microscope. So we need something to bypass these obstructions, these opacities, to make our surgery work. There are two options we have. First, we have temporary keratoprosthesis, and the second is endoscopy. In temporary keratoprosthesis, the binocularity and stereopsis is better, and you can perform bimanual surgery using temporary keratoprosthesis. But there are some issues like that you need donor cornea. Longer operating time is there because of you have to suture this keratoprosthesis. Because of the open sky situation, there are chances of developing suprachoroidal hemorrhage and chances of graft failure because of the inflammation and silicone oil in the eye. You may also require help of an anterior segment surgeon, and sometimes in some situations of ocular trauma, this watertight fixation of TKP is not possible in some situation because of the wound situation. The advantage here is the endoscopy, you have lesser surgical time, and that's why there are lower chances of developing proliferative vitreoretinopathy and retinal detachment. Severe trauma to the iris, lens, chorioretinal damage, intraocular hemorrhage, all these things may lead to proliferative vitreoretinopathy, and that may become intractable if it is not treated in time. The endoscopy allows early exploration of the intraocular structures in early intervention in trauma cases, and thereby it lowers the chances of PVR and retinal detachment. There is lesser surgical time. It is beneficial where TKP, temporary keratoprosthesis, cannot be used and the graft is not available. The one more advantage with endoscopy is that you don't require to indent the sclera to visualize, because in some in trauma cases or other vitreoretinal surgery, you need indentation to see the peripheral retina. But in endoscopy, you don't require indentation. That is an advantage. And this is very important because of the wound situation in these trauma cases. But there are some advantages and disadvantages with endoscopy. The bimanual instrumentation is not possible with endoscopy because one of your hand holds the endoscope and you have only one hand to perform the surgical maneuvers. There is lack of stereopsis and binocularity. The view is two-dimensional and you are seeing things in front of you on the screen. You are not seeing through the microscope, you are seeing in front on the screen. So there are issues of shifting perspective. Their depth perception is also difficult with endoscopy. Another problem with endoscopy is that the view is tunnel-like. It depends which gauge of endoscope you are using. The view may be 125 degree or 145 degree, whether you are using 23 or 20 gauge of instrument. Another irritating issue with endoscopy is that the focusing is controlled by the assistant. The control of focusing is not in your hand completely. Rotation of endoscope causes rotation of the field of view, and there is a definite learning curve with this procedure. Cost and availability of equipment is also an issue. But the endoscopy allows procedures that were not possible with microscopic view. So that is a major advantage in spite of all these issues and disadvantages. Intraocular foreign bodies are frequent in ocular trauma, and they need early intervention due to the toxicity issues. If intraocular foreign body is lying there for long, there are chances of developing sidrosis, calcosis, and there are possibilities of developing infection also. Delayed surgery may lead to encapsulation of the foreign body, making its subsequent removal difficult. Endoscopy allows early intervention, and endoscopic assisted vitrectomy is a valid alternative in these kind of situations. In post-traumatic endophthalmitis, we all know that EVS study confirms the benefit of early vitrectomy in endophthalmitis. Anterior segment opacities due to trauma can often limit the standard vitrectomy for endophthalmitis in these patients. Endoscope is useful in such situation to perform early vitrectomy. Another advantage of endoscope is that it helps in visualizing the anterior structures like ciliary body, which is often covered by inflammatory membranes in this endophthalmitis situation. So it helps in removing those inflammatory membranes from the peripheral areas. Endoscopy is a useful tool for diagnostic in trauma cases. We all know that ultrasound has varying sensitivity and specificity in picking up intraocular foreign body and retinal detachment. It varies from 70 to 85%. L.V. Prasad, Dr. Rajiv and his group has done this study, and it says that endoscopy ensures immediate diagnosis on table, and unnecessary procedures like keratoprosthesis and keratoplasty can be avoided. Prognostication of final visual potential is a very important dimension in management of ocular trauma. Endoscopy, by allowing a direct visualization of intraocular structures, gives a better prognostication to the operating surgeon as well as to the patient to assess the prognosis. I'll show you a small video of a patient who was 41-year-old male patient who sustained injury with an iron particle. Vitrectomy for intraocular foreign body removal was attempted 18 months back in this patient, but this patient came with secondary glaucoma, total cataract, and sidrosis. CT scan orbit was performed, and intraocular foreign body was found at anterior ciliary area. This is a small clip of the surgery. Cataract was removed in an attempt to, cataract was removed, and it was, the conventional view was tried to locate the foreign body, but it was not located on operating microscope view. So endoscope is used to visualize the intraocular structures. This is the cut edge of the vitreous through the endoscopic view. This is optic nerve and posterior pole, which is normal. This is the cut edge of the vitreous of the previous vitrectomy that was done. I am trying to locate the foreign body which is lying at the anterior ciliary body area. This is the foreign body lying at the anterior ciliary area. Now, with the help of the magnet, I'll try to pick and lift this foreign body from the surface of the ciliary body. But because of the adhesions, the foreign body is not coming with the intraocular magnet. So the cutter is used to remove the adhesions around it, and then with the help of intraocular magnet, the foreign body is lifted. But while lifting the foreign body and removing it, get stuck at the smaller size of sclerotomy. You can visualize this foreign body is stuck. Now with the help of blade, the sclerotomy is enlarged. In this process, the foreign body falls again on the posterior pole. Now with the help of this intraocular magnet, the foreign body is removed. So this procedure was not possible in the earlier surgery with the conventional microscope, but with the help of endoscope, we could remove the foreign body from the eye. Another common situation, which is also very useful in trauma patient, is doing diagnostic endoscopy. This is a small video of a patient who was referred to me for diagnostic, for evaluating the posterior segment. This is the endoscopic view of the patient who had corneal opacity because of the trauma, and you can see the peripheral chorioretinal atrophy and fibrovascular scars. The optic disc is normal, the posterior fundus looks normal on endoscopy. So this patient can be taken up for keratoplasty. If you see that the disc and retina is reasonably healthy, then these patients can be taken up for the surgery, because sometimes you cannot visualize actually the finer things on ultrasound, and also the disc can also be seen very big. This patient was operated by Dr. Abhishek Ithari at Jaipur. Keratoplasty was there, and this is the final picture of the retina that we saw. The patient regained vision of 6 by 12. So diagnostic use of endoscopy is also very useful in ocular trauma patients, so that we can choose in which patients we can perform penetrating keratoplasty with a useful vision. So in conclusion, the endoscopy has certain advantages over TKP and the conventional surgery. It allows early intervention, lesser surgical time is there are lesser complications. It provides more time for the surgeon to find useful corneal graft for the implantation. The post-operative inflammation is less severe after endoscopic surgery if you compare with TKP. But there are some disadvantages and difficulty. There is a quite steep learning curve, lack of stereopsis, limited field of view, and difficulty and inability to perform bimanual surgery is an issue with this, and the cost of equipment is also an issue. But whatever you say, the endoscopy allows procedures that are not possible with microscopic view. It is a very useful equipment in vitreoretinal armamentarium alone or as an adjunct to conventional method. Thank you very much.
Thanks, Puneet. That's an interesting talk on trauma and how to use an endoscope. While I'll ask Dr. Modit to go ahead and give his take on diagnostic endoscopy, using an endoscope and using for diagnosis of some conditions which might help us in managing the patients better. While he's setting it up, if there are any questions, we can take now. So Puneet, what do you think is the reason why there is less uptake of endoscopy in retinal practice?
I think there are 2-3 main issues. First is the cost of the equipment and the recurring cost of the equipment. And another technical point, if you see the view of the endoscope, there are the limitation of the view. Because of the tunnel-like view and lack of stereopsis, and you are not able to perform bimanual surgery, there are some limitations. Because of those things, the learning curve is very high, very steep. That may be the reason that people are not taking up this very useful modality, which is, I have seen in my experience, has helped in a lot of patients, which we could not have managed with conventional operating microscope system. I think the cost and the quality of view is an issue, but I think with the coming newer techniques and some newer innovation, these issues will be solved in future.
Yeah, Dr. Puneet, great presentation. One question that I asked, or that I wanted to ask is, the video that you showed had a largely clean-looking vitreous cavity, but often in trauma, we are faced a situation where you put in the endoscope and then smack, you have the hemorrhage right there in front of the camera, and only thing that you see is bright red light and no details whatsoever. So how do you approach in those situations?
It is said that with endoscopy you can perform procedure relatively earlier, but if there is active bleeding, I think it is impossible to do surgery even with any view. So you have to wait for a couple of weeks to get the hemorrhage or things organized. Only then I think you can. Dr. Rajiv, what is your?
What I usually do is try to clear the anterior vitreous. Most of the times, unless there is a complete no view, you might still be able to see some amount of anterior vitreous, and then you can actually remove a little bit of an anterior vitreous where the blood and everything is there. And moment you start seeing your endoscope with a cutter inside, so that's the time when you can actually go ahead and start using an endoscope to clearing it. What I usually do is a external clues. So when I'm doing with endoscope, I go with an endoscope towards the active port, that is where my cutter is, where I'm entering in. So that means I'm directing my endoscope probe towards that port where I'm entering in, and the moment you go inside, you'll be able to see that cutter there. Most likely you will have a clarity there, and if you have done a little bit of anti-vitrectomy there, it gives you a area where you can actually see the cutter. And once you start seeing that, go extend it along with that. So don't let the view of the cutter be lost. So that's the only clue which I would say which can help you to do that. So I don't wait for 2 weeks, I go ahead and do it earlier.